Good morning. Are you guys having fun so far? It's been quite a day at the Expo, yeah? Yeah, good stuff. Lots of good stuff in there. So we have our keynote speakers now. Very, very excited that we get to announce for you. We're going to hear from MultiCare's expert team of orthopedists. We have Dr. Blumenthal, Dr. Calderon, and Dr. Strasser. They're going to discuss their best tips for remaining active as you age and how to identify if and when you should talk with your provider about joint replacement. Panel discussion will also end with a Q&A portion, so save your questions for the end and we'll get to them. Hopefully they'll have some good answers for you. Yeah, let's see if we can get our event staff. There we go, okay, they will be turning off that music momentarily. And there is the moment. Okay, so first up we welcome Dr. Allison Blumenthal. Thanks for being here.
Welcome everyone, thanks for being here. We're excited to be able to speak with you and have in-person events again. This is exciting. So as you know, the three of us work for MultiCare, and you may or may not have seen our pictures around town. So this encompasses our entire orthopedic provider team. It ranges anywhere from hand surgery, total joints, sports, non-operative orthopedics, and we're all excited to be a part of the Spokane community and provide care as needed. So who we are is I'm Dr. Blumenthal, as she introduced. My focus is orthopedic surgery and I'm fellowship trained in sports medicine. We'll kind of delve into that. Dr. Strasser is a primary care sports medicine provider. And then Dr. Calderon is another orthopedic surgeon who is fellowship trained in total joints. So we're all here because we're passionate about active living, right? That's the whole idea behind this exposition. But you don't need us to stand up here and tell you that it all starts with a healthy diet and staying physically active. But what happens when injury or just degeneration comes into play and prohibits us from being as active as we want to be? That's where we come in. So there's a variety of different treatment options, anywhere from the spectrum of non-operative, as we'll get into a little bit later, to operative intervention, and there's different varieties within that as well. So that's what we're here to talk about today. So myself, I grew up in the Midwest, went to Southern California for undergrad, back to the Midwest for med school and residency, and then back to Southern California for additional training for my fellowship. And I'm very excited to be up here in the Spokane community. Moved here less than a year ago, so it's great to be able to meet and see some faces finally and be out in the community. So we appreciate you guys being here again. So what I specialize in is what's called sports orthopedic surgery. Now, it derives its name mainly because a lot of our injuries that we treat do come from athletic injuries or sports events, but that doesn't necessarily mean you have to be playing baseball or football to get some of these injuries. Mainly it focuses on ligament reconstruction or repair, as well as just the joint itself, being able to preserve that with any injuries that arise. There's also soft tissue debridement, or what we call cleanup procedures, when you have some minimal arthritis but some soft tissue damage within the joint that we can do. And we do this all through what's called a minimally invasive approach, or another word is arthroscopy. That literally means to look within the joint. So we do that through minimal incisions, and by doing so we're able to look with a video camera and see the joint, so without having to make a large incision to actually open up the joint and see that. So usually the incisions of the surgeries I do are poke hole incisions about 1 centimeter in length. As you can see on this nice image that I stole from the internet, we have nice little poke hole incisions. This is where the video camera can come in, and we can do most of our work through those incisions with small tools and be able to see on a video screen, as you can see in the right hand corner here, everywhere inside the joint that we need to see. My areas of focus are anywhere from the shoulder, hip, knee, and ankle. I do these minimally invasive procedures that way. Again, it's a subset within orthopedic surgery that we're able to provide some of these procedures. Again, ligament reconstruction, tendon injuries, things like that we can get repaired, as well as some cartilage damage. Now that only goes up to a certain extent. Obviously, if someone has advanced arthritis, there's other options that are likely better for you, which we'll get into as well. So at this point, I'd like to introduce our next physician, Dr. Strasser. Come on up.
And stand behind that. Good morning, everyone. My name is Strasser. Hot mic. I'm a primary care sports medicine doctor, so I'm a family medicine physician by training. And then I did extra training in sports medicine. So it kind of puts me into a really fun position where have a background in medicine and I understand kind of the whole person approach, but I can focus specifically on activity, active living, and different ways that I can try and keep you out of my colleagues' hands. That's my real goal. So. All right, I was not born but raised in Spokane here, so a local boy. Went to Lewis and Clark High School and then moved away for life and training and came back about 15 years later and have a wife and a couple kids and it's been really fun. Been back for almost 5 years. Since I've been back, they've given me some really neat opportunities. I serve as a medical director for Hoop Fest, so I oversee all the medical tents for Hoop Fest. I'm involved with Bloomsday, I oversee Junior Bloomsday, some local high school stuff, and then I'm also the medical director for Eastern Athletics. So I get to oversee all the Eastern athletes, make sure they're out there chasing down another national championship, and maybe we can get another Cooper Cup through the ranks if we're doing all right. All right, so primary care sports medicine, we talked about that. So a little bit of what I wanted to talk about today was the importance of activity. You know, what is activity and why is it important objectively? Because we all hear that and it makes sense, but really what does it do? For me, activity is relative to the patient or the individual. It doesn't mean that everyone has to go out and run a marathon or participate in a contact sport to be active. It can be feeling stable, getting up, going to the bathroom at night. It can be cooking for a prolonged period of time without feeling weak in the legs. It can be taking a walk with your kids, grandkids, and great-grandkids. So there's a lot of variability there, and I think that one of the fun parts in my background and training is I get to know my patients well enough that we can come to common goals of what activity you're at and where you'd like to be and how we can get there. Couple of nitty-gritty things, you know, the United States Preventative Services Task Force recommends 150 minutes of moderate activity per week. I think you can do somewhere between 70 and 90 minutes of more vigorous activity. Moderate activity would be taking a walk, walking the dog, that kind of thing. Vigorous activity would be adding elevation, increasing the speed, jogging, pickleball, which apparently is all the rage right now because I've been seeing a lot of patients with pickleball injuries. But at any rate, what we like about activity is it reduces all-cause mortality, which is a really fancy way of saying it makes you healthier. It reduces your diabetes risk, it reduces your hypertension risk, it reduces your cholesterol risk, your heart disease risk, it improves lung function, it improves balance, it helps mitigate some of the risk of falls. It's all around, it's just a good thing to do. But again, keeping it in the context of what you are able to do and what you're safe to do is an important factor. Looking at mental health, that's a big part of what I do as well from the primary care side. If you look at how we treat mental health, it's kind of a three-pronged stool, right? There's counseling, there's medications, but the biggest and strongest leg of the stool in my book is physical activity. It's been shown to be as good, if not better, than your antidepressant, anti-anxiety medications for folks. So I'm always telling people, listen, for no other reason, forget the physical stuff. You live a stressful life, we live in a stressful time, get out and take a walk. It's going to do amazing things for your mental and your physical health. Keep cruising along here. Okay, so focus for active and healthy living. Again, common sense stuff, right? Sleep is critical. You have to get as much sleep as you feel you need. And people ask me that, well, doc, should I get 6 hours, 7 hours, 8 hours, 9 hours? I don't care. Go to bed when you want, but the ideal is go to bed when you're tired, wake up at the same time every day as often as you can. And if you're doing those two things, your body will start to auto-regulate, and you can really find that appropriate amount of sleep. Meditation, really again focusing on that mental health component of active living. And you can do a variety of different types of meditation. I think there's probably 400 apps if you Google meditation apps. So those are always nice as an adjunct to follow along with. But in truth, anything that quiets your mind and gives you a moment to rest and recuperate is important. Nature walks. Some interesting stuff I was reading in the past few weeks on the health benefits, lower diabetes, lower blood glucose levels, lower blood pressure levels, associated with 3 20-minute walks in a natural environment. Pick that natural environment, but something calming, something outside if you can. Luckily, it's a beautiful weekend. We can actually start enjoying it after our 9 months of winter. But overall, if you can get outside, do it. Community involvement. Active living is best seen in community. So whatever that looks like to you, whether it's a church group, a weekend group, a community group, whatever it may be, but living in a community setting has been shown to be helpful for a number of reasons. Obviously, it helps with your overall well-being, but it's also one of the ways that you can hold each other in that community accountable for your health. Hey, are we walking together? Hey, are we, keeping an eye on what we're eating? Are we keeping an eye, how's your sleep? How's your mental state? And all those things, as you build that community, kind of gives you that safety net. And then consistent eating habits and hydration. People ask me how much water to drink. For my athletes and kind of folks in their 20s and 30s and 40s, I tell them 1 ounce per pound of lean body weight, but that can quickly add up to over a gallon, which is pretty burdensome. So, so that you don't have to get up and use the restroom 16 times a night, I recommend the old classic is drinking water until your pee is clear. So forgive me if that's too vulgar. That's what we have stapled all over the Eastern Athletic Room. It's like, just be clear. Yep. Let's see what else we got here. Okay, so non-surgical orthopedics. So what does that look like? So I'm just a member of the team. I kind of see myself as a quarterback, not because I'm in any way supremely talented, just because I help coordinate a lot of different positions. Physical therapy is going to be critical. That's that true physical component, physical strength, balance, training, and avoidance of falls, which is key. Massage therapy, everyone loves a good massage. So ask your doctor about massage therapy. It's something that I think is underutilized. Chiropractic, I like chiropractic a lot. I think you have to find the right chiropractor, just like you have to find the right surgeon and the right doctor. But find somebody who understands your medical background and can give you a good assessment. Medications and injections. So this is more getting into the specifics of knee and hip and shoulder pain and associated arthritic pain. There's a lot of options, but I'm the doc who does the ultrasound-guided injections to try to buy you time until you have to see my partner who will talk to you next. The thing for me with those is, and I tell this to patients, and I don't mean to sound rude when I say it, but I don't care as much about your pain. I care more about your function. So I want to make sure that our common goals that we're finding as I'm working with individuals is to say, hey, you want to be here, great. Here's the different tools you have to get here. It's going to be a lot of work on your end. But if I can buy you 6 to 12 months of reduced pain so you can push through physical therapy, you can push through your daily exercises, you can improve your overall function and stability, awesome. That's what we're all about. So that's where that comes in. Hyaluronic acid, it's a grease shot for the knee or an oil change for the knee. It's a lubricating injection. It's another just tool we have. And then platelet-rich plasma gets into more regenerative medicine, it's called. I think it's a bit of a misnomer, but it can help reduce pain, and there's some other options along the way there where we actually draw out your own blood, spin it down to certain components, put it into the knee, hip, or shoulder, and there's some different discussions there, but at least want to give you a taste. All right, barriers to surgery. So to set up my partner here, talking about what happens when we get to a place where I can't help you anymore. We've done the injections, we've done the physical therapy, we've done the weight moderation, and you go, my knees are functionally limiting and excruciatingly painful. And you'll know when that time comes. And then you can start talking about total joint replacement, what that looks like, what are the indications, what are the expectations. Of course, would defer to Dr. Calderon, but a few things that I try and do before you see that team to make sure you have a successful and a fruitful visit. Number one, do you have diabetes? If so, it needs to be controlled. A1C below 8, preferably below 7. Okay. Number two, tobacco use. If you're a smoker, quit. You should have quit years ago. Let's get on it and we'll just take care of it now. Cold turkey is better than the slow trickle method, and it usually takes about 7 attempts to quit completely, so give yourself some credit, but if you're a smoker, let's at least start it today. Number three, elevated body mass index. So your BMI is a measurement of your weight in relationship to your height, and so we just spits out this random number, but we know that there's certain markers, and what we want to do is get you below 40 and ideally below 35. If you're below 40 and certainly below 35, you become a much better candidate for a total joint replacement, and why do we do that? Much higher chance of a successful surgical outcome. And then number four, kind of as a catch-all, uncontrolled chronic disease. So if your blood pressure is 190 over 110, that always perks me up, and we try and get things figured out for you. But those are the types of things that are really going to limit you when you start talking about total joint replacement or surgical intervention. Kind of as a closure, looking at the whole body approach to health, the more you move, the better you'll be for longer. That's the key. You just have to keep moving. Reading all these studies, all these advanced interventions, things we do, at the end of the day, exercise and activity is probably the greatest prognostic indicator for successful outcomes, not only with osteoarthritis or joint problems, but the function you carry into surgery is the function you carry out of surgery. So the better you are beforehand, the more teed up you are. I get to serve you up on a silver platter to my partner and get you taken care of, but it's just a much better chance that we'll keep you successful, keep you moving. All right. Thank you, I appreciate it. Dr. Calderon.
So Nick does a much better job of teeing up my patients than coordinating our outfits. So we were right into the color of our shoes and our belt. So I didn't get that part right. Other than that, he's 100%. So after you've worked your way through Nick and Allison, you wind up in my clinic. I'm a total joint replacement specialist at MultiCare. I've been practicing for 14 years. Did my undergrad at the Air Force Academy in Colorado Springs, spent some time in the Air Force, bouncing around, as well as in Afghanistan for a little while. Med school at Rutgers, residency at the University of Arizona, and then finally fellowship at Duke. So fellowship was a 1-year specialty training where I did nothing but hip and knee replacement and revision hip and knee at Duke. So my specialty, so these are just a couple pictures again that I did like Allison, stole off the internet, but on your left side, we're gonna show you the normal hip and knee, so hip, knee. And what we're looking for here is we're looking for the joint space, and it's highlighted on the left side there. So a fairly normal joint space on, let me go back, on x-ray. So on x-ray you can't see the cartilage, but what you're looking for is a space between the two bones. So on the hip x-ray, we're looking for this space and then no space there. So you can't see the cartilage on x-ray. Cartilage is mostly water, so it doesn't show up, so you're looking for that space. You don't need any advanced studies for my practice, so no MRI, no CT. This is all I need is a simple weight-bearing x-ray. On the right side of the screen is a knee, similar concept. We're looking for that joint space. And when it's gone, you have bone-on-bone arthritis, and that's where I come in. So some conservative options. I still do try to do some conservative measures. Even if Nick has tried some, we still have some other options that we usually can try. Weight loss is a big one. Nick mentioned BMI. We shoot for BMI under 40. There's been some literature out there that supports BMI under 40 has 3 to 6 times more likelihood of having a successful outcome after joint replacement surgery. Activity modification, if it hurts, don't do it. Similar concept. NSAIDs or non-steroidal anti-inflammatories such as ibuprofen, Motrin, Naproxen, etc. And injections. Nick mentioned these. He's our specialist. He may end up in my clinic. I'll see you and then refer you back to him for an injection if we don't feel like you're ready or you're not ready for a joint replacement. Again, that's what Nick mentioned is steroids, viscosupplementation, the artificial nucleant part, as well as PRP, the plasma, or the platelet-rich plasma. And then finally, when you're ready, this is what a total knee versus a total hip looks like. So we basically go in, we cut out the arthritis, the diseased cartilage, we cap the ends of your bone with metal, so knee here, hip here, and then in between here is a piece of plastic. It's polyethylene, or polyethylene. And so that's the space there. It's not cartilage anymore, but it's a piece of plastic that's replaced your cartilage. What I like to tell my patients is, when you get to a point where your knee or hip is dictating life, so you wake up in the morning thinking about your hip or knee, you modify your activities all day long because of your hip or your knee pain, you go to bed thinking about your hip or your knee, that's when you need to come to me and we need to talk about hip or knee replacement. It's an entirely elective procedure, so you're going to make the call when or if you ever have it done. As far as once we pull the trigger to have the hip and knee replacement done, this is our usual protocol. Most patients will spend 1 night in the hospital, but not everybody does that anymore. So we're transitioning more to an outpatient model where you come in the morning, have your surgery, and then go home in the evening. We screen you thoroughly, make sure you have a good support system, and that you're a good candidate health-wise in order to be able to do that, but we are definitely transitioning more towards outpatient surgery. For the first 6 to 12 weeks, you usually do some sort of physical therapy. Hips don't need it as much as knees. First 6 weeks, we're focused on range of motion. Second 6 weeks, we really push hard with muscle strength. You will have a lot of atrophy after surgery, so we focus on trying to build that muscle back up after surgery. 1 year for full recovery. Hip or knee, 1 year. However, at about the 6 to 12 week point, that's where patients typically come into my office and they say, I'm glad I did this. This was the right decision. So By 6 to 12 weeks, you're usually feeling pretty good. You're able to do those activities again, but full recovery is not until 1 year. Outcomes from hip or knee replacement are excellent. So you have an 80 to 85% chance of having a good or excellent outcome. So it's a great surgery as far as major surgeries go. And that's it.
Open the floor to questions now. I'll call anyone.
All right, guys. I'm going to bring these two up here again, make them work today. Questions? Yes, ma'am.
So is there any benefit to liquid collagen, taking liquid collagen for joints?
Good question. Like the liquid, like collagen supplements, or if you look at glucosamine and chondroitin sulfate, the evidence I think is pretty mixed that it has any significant benefit objectively. I tell my folks, I go, anecdotally, it probably won't hurt you. It may help you, but statistically, it probably is of not great benefit. Is that true? Make sure you guys know anything else. Yeah.
A lot of hiking, and sometimes my left knee has a feeling that it doesn't bother me, it's not pain. But my question is, am I harming it by using it? I love the functionality, and I don't care about the pain. But if I hurt it, why not do it partial stopping or something?
That's a great question. It's a question we actually get a lot. So I usually advise people, it's up to you what you can tolerate, and I think it's a bad idea to discourage people from being active. So if you feel like you're happy with where you are at function-wise, you can tolerate the discomfort, for the majority of the time, by all means, please be active and continue doing what you enjoy. There's not much you can do to continue to harm it. Now, that's being said with the sense that arthritis or degeneration can always progress. However, I don't think that by you continuing to hike or doing that is going to advance that significantly enough where we would say you need to not be as active anymore. So to answer your question more succinctly, yes, I think you should continue to be active, do what you can tolerate. As soon as it gets to the point where you feel like it's inhibiting you from being able to be as active as you enjoy, that's when it's important to talk to your doctor and kind of see what other options there may be if needed.
Okay, thank you.
I would skip the trampoline part, but you can go for hikes as much as you want.
I have recurring bursitis in my hip. What brings that on?
It's a great question. Can I take this one? Okay. So you're talking bursitis on the outside of the hip there, where it hurts, and then it hurts to sleep on that side?
Yes.
So the recurrent bursitis is an inflammatory process, but most often, and this is where I get a little geeky on the biomechanics, the reason people have recurrent bursitis that hasn't been addressed is because they have a dysfunction of their gluteus muscles. It's one of my favorite diagnoses. I call it dead butt syndrome. And basically what happens is you don't use your glutes, and it's really a functional instability and can be addressed quite well with physical therapy and even sometimes surgical intervention with one of the sports surgeons. Because if you have a tear of the musculature that attaches to that point, it doesn't matter how many shots you get, doesn't matter how much you do, sometimes it just won't get better. But the more you can work on core stability, pelvic stability, balance work, the trochanteric bursitis is often a byproduct of a poorly function or a poor stability of the core. And so if you can focus on the core stability, a lot of times that bursitis will take care of itself.
Well, say we had physical therapy and then it helped, and then I'm like 2 years free.
Yeah.
I go to Y 4 times a week. I do water aerobics, I do core activity, and a lot of it. And so the pain is tolerable, but it's still there.
Yeah, in that case, I would consider what I call diagnostic and hopefully therapeutic steroid injection. I'd say come in, try a steroid shot, and if it helps, then we know that's exactly where the pain's coming from. If it doesn't help, then we can start to take that 30,000 foot view and broaden our approach. What else could be? Yeah, great question. And kudos to you for working out so much. That's great.
I have a bone-on-bone knee, and I have a bone broke from the inside, and it's forcing my leg out breaks this way. Somebody suggested an offloader brace. Does that make sense?
Yeah, so we used to prescribe offloaded braces a lot, and I still do occasionally for younger patients, but there have been some recent studies that show that they really are not effective, and they're quite expensive if your insurance doesn't cover them.
I heard Dr. Calderon say that he doesn't need MRIs. I think that's interesting. It seems like they're ordering them all the time. So when are MRIs needed?
Sure, so there are some special occasions where so specifically when patients have retained hardware, so you've had a femur fracture, you've had an ACL reconstruction, or you have some additional hardware around your knee or hip where traditional instruments aren't going to work, I'll get an MRI or a CT scan where we can actually build patient-specific blocks for you. That way we don't have to rely on the traditional instruments and try to go in and remove all that old hardware. We can just have the MRI or the CT done, build the blocks, and we can work our way around the hardware that's retained.
I'll add to that. The MRIs usually come and play with my specialty. So we always usually start with x-rays. That gives us a great look at how your bony anatomy is, if you have any advanced arthritis, how your overall alignment is, how you were structured. If you have relatively maintained joint spaces, like Dr. Calderon showed on some of those x-rays, then that's where we start to, if you are continuing to have pain, which is usually why you're in to see us, we start to think about what are some other reasons why you may be having some of that discomfort or pain or structural issues. So what x-rays show us are the bones and how your alignment is. They don't show us the soft tissues and other structures. So typically, again, if you have on x-ray well-maintained joint spaces, we may look further with something like an MRI that will show us those soft tissues, things that are called the meniscus or cushioning of the knee joint, more of those soft tissues. If you're looking at the shoulder, maybe the rotator cuff is an issue, things like that. So they are, like you said, frequently ordered, and often patients have them even before they come see us. But there's different kind of spectrum of where you're at personally as far as your journey in your pain. So.
The root cause of arthritis. Could you explain that?
So I'll just give you my quick. Sure, absolutely. He wants to know what the root cause of arthritis is. There's several different arthritis categories, right? There's osteoarthritis, which is a wear and tear. There's rheumatologic arthritis, so like psoriasis or RA, where your body has produced antibodies or is kind of destroying your cartilage on its own. So, and there's psoriatic arthritis. There's all types of arthritis. The vast majority of what we tend to see is osteoarthritis, which is wear and tear. So the way I describe it to my patients is it's like the tread on your tires. So the more cycles you put on your tires, the sooner you're going to wear through that tread. It's the same thing with your knees or your hip. The more cycles you put on it, eventually you wear through that cartilage, and you're going to end up seeing one of those.
Can it be avoided?
That's a great question. Eventually, I think if we all live long enough, we're going to end up with some arthritis somewhere in some part of our body. Not necessarily our hips or our knees, but that's the way I feel.
Yeah, I agree. I mean, it kind of gets back to, to me, we don't treat the x-rays, we treat the patient. So, yes, if I take an x-ray of everybody's knees in the room, am I going to find a fair amount of arthritis? Sure, maybe, even in us. But in truth, what's your function and how capable are you? What I tell my patients is I don't want the fear of arthritis or degeneration to shy them away from activity. Because if you look at risk of morbidity and mortality, it's a lot higher for heart disease, diabetes, and whatnot than it is for arthritis. So it's better to be active and not worry about it as much, and then we're here if you need us. And I think there is a bit of a genetic predisposition. There's some epigenetics, meaning not only your genetic predisposition, but how you lived, what you did. And of course, injury patterns can be a part of that. For us, we see a lot of sports injuries, including ACL ruptures is a common one. That's a known risk factor for earlier onset arthritis. So there's a few kind of other points to it, but yeah, it is a bit of a wear and tear pattern.
I had rotator cuff surgery on my shoulder, and after 6 weeks of being in the brace, the sling, I got arthritis in my right wrist. Is that going to go away, or is it going to get worse, better?
Tough question. I think, whenever you do a new, well, again, it was immobilized for that time, and so likely you had underlying arthritis, but it was flared in its inflammatory pattern because you reduced movement. And it an answer to the question, it reiterates the importance of activity. Will it get better? It should as you come out. When was your rotator cuff tear? Or rotator cuff surgery?
A year ago, May 7th.
A year ago, okay, yeah. Yeah, I mean, the hope is that your wrist will continue to get better. Sometimes directed treatment at the wrist can help as well, but it is challenging. Things start to rear their head. And also, your body does really amazing things with pain. So if you're in a severe amount of pain with your shoulder or your hip, and then all of a sudden that gets fixed and that pain signal comes way down, all those other pain patterns sometimes rear their head. So your wrist may have, and I can't guarantee it, but it may have been bothering you in some capacity, but your body was really registering more of the shoulder pain. And so as that's gone away, it kind of rears its head, but tough to say. Good question.
Other than knees and hips, is there something you can do for other joints, like hand joints, wrist, thumb?
Absolutely. The themes of today, the themes of today really apply across the board to any joint. So we have orthopedic hand surgeons on staff, we have foot and ankle surgeons on staff that all focus in those different regions. I'm kind of an inch deep and a mile wide, so I'll inject almost anything. Yeah, it's fun for me. No, it's clinically interesting. But in truth, yeah, so if you have arthritis in your thumbs, which is really common at the base of the thumbs, we can do ultrasound-guided steroid injections in there. Same kind of theme, physical therapy, activity, functional expectations and improvement, occupational hand therapy, things like that. So, yep.
My question has to do with, if you have bone on bone in a hip situation, is there any kind of injection that would help that? I mean, or is joint surgery only an option?
Great question. You okay if I take this one? I'm on a roll, guys, so let's just keep it going. I tell people that arthritis is treatable but not curable. In other words, I don't have an injection to reverse the arthritis or the joint space narrowing, or a treatment option or a medication. We're really band-aiding it along, maintaining that function until it gets to a place where you do go see Dr. Calderon. To answer your question. So there isn't an injection to reverse the arthritis.
If you have an injection like that, is there any sense of how long it should last? I mean, if it's bone on bone and you do an injection, does that help for any length of time, or is it just so very well targeted?
Great question. I tell my folks that the more severe your arthritis, the less likely the injections are to be prolonged in their efficacy. So the worse the arthritis, the less likely it is to work. I still think it's worth a trial. Ideally for us, to maintain systemic safety, we don't inject a single joint more than 3 times in a 12-month time span, nor do we do it in closer than 3 months in succession. So if you get an injection and it lasts 4 to 6 months, great, we can repeat those for 10 years, that's not a problem. But if you get to a place where you do the injection, it only lasted 2 to 3 weeks, now, and you're back to being functionally limited and in severe pain, that's a good indicator for me that it's time to get you over to the surgical team.
What does the injection do?
So it depends on which type of injection we're talking about. Steroid injections for hips and shoulders and whatnot. The real underlying mechanism is it interrupts the inflammatory cascade, so it's going to reduce inflammation in the joint. It's the same, it's not the same, but it's close to taking naproxen or ibuprofen, but instead of it being systemically absorbed and affecting everything, it's directed in a much more concentrated fashion into that single location. And each of the joints has a lining around it, a joint capsule that kind of holds stuff in, and so it helps maintain that medication in that joint itself.
Do you recommend having that sort of thing done before you make a decision on surgery? Yeah,
I think, and no offense to my colleagues, but I think surgery should be your last option, and I think they would agree that when the time is right for surgery, that's what it's there for. It's an amazing tool, and it's life-changing. But until you get to a place there you go.
So he's absolutely right. The one thing that I would add is, if you're going to consider a steroid injection, you have to understand that everybody responds differently to steroids. So some patients swear by them, they love them, they work forever, and some people don't. So the only way we'll ever know if it's going to work for you is to try it. However, if you try it and you're one of the ones who does not get any benefit from it, according to the literature, you should wait at least 3 months, some say 4 months, after a steroid injection before you have surgery. So if you go have that steroid injection, it doesn't work, you're still in severe pain, you got to understand that we're going to have to milk you along for that 3 to 4 months before we can safely do a joint replacement on it.
Are there any options for degenerative discs in arthritis in the lower back?
There certainly are. I think that's outside of ours, at least the two of us scope. I'm sure you probably divvy through quite a few of those.
The themes in medicine, right? So yes, the options are going to be similar. The better your activity, the better your core strength, the better your mobility balance, the more likely you are to prolong until a surgery is required. I couldn't speak with expertise as to what surgeries would be an option. That would be one of my neurosurgeon colleagues. But I do know that either I can kind of get you started and get some things going, but a physiatrist or a physical medicine and rehabilitation doctor, which we have a number of, are really the non-surgical specialists, and their biggest tool in the tool belt, if you will, is a steroid injection, image-guided steroid injection into a degenerative disc or degenerative facet joint in the back.
I have both my knees replaced. One's 20 years old, one's 15. I've been a very active person my entire life. And this last year, not my oldest one actually, I'm about 15 years old. It does not like to go down hills. Where we live, I love to go up the hills and come down. And all of a sudden, I'm not doing that because to me, I think it's going to crash on me. And so I don't know what to do. I want to be happy, but I don't want to, you know,
Yeah, so very common complaint. So knee or hip replacement surgery is not perfect. It won't last forever. So the failure rate for knee or hip replacement is about 1% per year. So that means at 20 years, 80% of them are still doing well. But as you start to develop pain, that tells us that something's going on inside the knee or hip, in your case the knee, meaning that that could be aseptic loosening, which means that the actual metal is separating from the bone. That's the most common cause for knee replacement failure. Or that piece of plastic that I talked about earlier that lies between the two pieces of metal, that can actually wear out. And sometimes it's as easy as going in and swapping out that piece of plastic, but sometimes we need to look at taking out the actual metal and replacing it with more metal. Yeah.
I've had one total replacement, probably ready for another one. Last time I was in to see the doctor, he said, well, you do need a replacement, but you don't recommend it because of your age. What are the dangers of doing it? I'm 84, just about 84.
So 84 is about a baby in my clinic, so that's about average for my clinic. So I will tell you the oldest joint placement I did was on a 91-year-old guy who 6 weeks after surgery, he went to Vegas with his girlfriend. So everybody's very different. So,
Is that part of your program?
yes, absolutely. That's the platinum program. But no, so age, you know, the cliche age is just a number, so it all depends on your health status. Before we do any kind of surgery on you, we will have you checked by your primary care team. So that means your PCP for sure, but if you've ever had a heart attack, we'll send you to your cardiologist. If you have rheumatologic disease, we'll send you to your RA doctor. If you've ever had a blood clot, we may send you to hematology. So we do a thorough workup before we do it, and we get everybody to sign off. And what I tell my patients is that we're going to do a thorough workup, we're going to optimize you. Right? We're going to check your meds, we're going to make sure everything is absolutely optimal for surgery. So 84 is not too old for surgery. Yep.
Do you have any comments on getting epidural treatments for cervical spine problems? I've got a massive displacement of my T4 cervical spine vertebra, and it's sliding off my back. And I think that being a chronic pain worsening situation with it.
Yeah, I think it's a not completely dissimilar to the hip or knee or shoulder, which is more in my wheelhouse, but I don't think it's out of the question to exhaust all non-surgical option. Neurosurgery, and again, I don't need one of my neurosurgeon colleagues to speak on this, but the success rates of that I think are variable when compared to, or are not quite as good, I would say, when compared to hips and knees. Yeah, and so Even more so than in our world, you want to exhaust all non-surgical options. So I think it is a worthy trial. It's scary to put a needle in your neck, to be frank. But when you look at the risk-benefit, which everything in medicine is risk-benefit, there's no 100% guarantees. I do think as it becomes more unstable, it's something to try. But again, getting back to arthritis is one thing, but instability is a bit of another. And when the arthritis leads to that instability, that becomes a greater concern.
How often is there infection following a procedure?
So that always depends on the procedure, of course. The procedures I do, since they do tend to be smaller, much smaller incisions, then the infection risk is much smaller just because of that. We still give every patient IV antibiotics the day of surgery before they undergo any surgery. And depending on the procedure, I may give them a few oral antibiotics to take for the next couple days. In my world, it's considered less than 1%, and by giving you kind of those antibiotics through your IV, that's minimized even more. But that's a great question because that is always a risk, and it's a very, when that does occur, that can be devastating. So I'll let kind of Dr. Calderon give his 2 cents on that.
Yeah, no, we do the exact same thing in hip and knee surgery. You get a dose of antibiotics before surgery, and then you get at least 1 dose. If you're going home, you'll get an IV dose before you go home. If you're staying, you'll probably get 2 to 3 doses of antibiotics. But the risk for an infection after a joint replacement is about 1%. Yeah?
Is your office in the realm of treating like labral hip tear repairs? Does that work?
Yeah, so that's where I come in. Again, it's nice that the 3 of us are kind of here. We're a little bit on that spectrum of where you're at with as far as treatment, from non-operative to kind of the last resort as far as joint replacement, and things like labral tears is where I come in. So more of those soft tissue structures around the joints, things like that are definitely something that I see frequently. And again, it all depends on kind of how your bony structure is. So I'm not here to stand up and fight for patients with this guy. We share a lot of mutual patients that way, but by the time you have that advanced arthritis, he's probably the one to go to. If you still have good joint space, but it's more of those soft tissue structures within that, then it's me that kind of take care of that.
I'm sorry, I was late here, so I didn't realize that you already spoke.
Oh, no problem, yep. No, good questions.
If I remember that slide correctly, back to the injections, it says steroid injections and some other kind of injection. What was the other one and what are the differences?
So the steroid injections can be used at basically any joint in the body. There's reasonable evidence behind them. There's a risk, especially in the weight-bearing joints. They can predispose you to earlier onset or more rapid progression of your degeneration, so it can make your arthritis worse faster. But again, it's that risk-benefit or cost analysis to say, is it worth pain relief? The other type of injection we commented on was viscosupplementation, also known as hyaluronic acid. If you tell your doc the grease shot for the knee, that they'll know what you're talking about. It's only FDA approved for the knee, so we can't use it in the hip or shoulder, unfortunately. I would love to do it in the ankle, hip, and shoulder all the time, but it's just for knee arthritis at this time. Yeah.
Deal with neuropathy and you go over to treatment.
Depends. Yeah, yes is kind of the broad answer. It depends on where the neuropathy is coming from. Is it an impingement? Is it radiculopathy coming from arthritis of the neck or the lower back? Is it a diabetic neuropathy coming from irritation? What's that? The first one? Yeah, so if you can get to the root cause of it, of the radiculopathy, and address it, a lot of times it can improve, whether that's, not to sound like a broken record, steroid injections, physical therapy, weight reduction, activity modification. The more you can alleviate that narrowing or really the inflammation around the nerve roots, the better. I think a common misconception, and correct me guys if I'm wrong here, is that your arthritis pinches the nerves, and while it can have direct contact, more often than not what it does is it's a pro-inflammatory state, and that inflammation in and of itself is what squeezes the nerve roots, which is why a lot of times with acute exacerbations of radiculopathy we'll use oral steroids to just calm it down, because if you can get that inflammation down, it alleviates the pressure on the nerve roots and subsequently can help with that. if there isn't a way to do that, or you're at kind of your baseline, there are some other medications out there like gabapentin or Lyrica, pregabalin, that can reduce the hypersensitivity of the nerves and start to make them not so burning and active. And a lot of people find that to be really tolerable. I like gabapentin because it has a massive dosing range. You can go from 100 milligrams up to like 3,600 milligrams, and everything in between. So it's not fun to dose, but it gives you some options, which is nice. Nice.
I've had arthritis in my left hand here for a long time. What I've noticed is that if I exercise my fingers, I pull the weeds or something like that, arthritis is really at a minimum. But if arthritis is caused by not having enough irrigation or whatever, more usage of my hands make it feel so much better.
Yeah, so that's a great question. So the more that you're stationary or not moving certain joints, then the more stiff and then in turn painful they can become. The whole idea behind movement is, like you alluded to, having that fluid kind of lubricate the joint. So if you think about the more mobile you actually are with that, the more that joint fluid can continue to circulate throughout the joint and actually keep that feeling better for you. The other thing is some people tend to say their worst of their pain is at night, and that tends to be when you're finally relaxed, you're not focused on other things, and your body says, hey, this hurts. So by keeping yourself busy and active, that also helps not to kind of focus on that discomfort or that pain. But again, keeping that joint lubricated and mobile is really important, no matter what area of the body it is.
Okay, and I have one other question about my arthritis. The CBDs, are they good for, in other words, a CBD salve?
Yeah, people ask me about, sorry, I didn't mean to. Yeah, people ask me about CBD, THC, topical medications. Unfortunately, there aren't really good studies due to federal restrictions in the past. We haven't done a lot with them that I'm aware of. From my patients telling me they like it. Again, it's one of those of similar to glucosamine, chondroitin sulfate. Is it going to hurt you? I'm not sure. I can't recommend for it or against it. We don't have a standardized policy or what's the word I'm looking for? Yeah, protocol or societal recommendation for or against it from the national level. But I've had patients who tell me it changed a lot for them and they did well afterwards. Yeah, I don't have a good, strong. This is my opinion.
Just to piggyback on the gentleman's question, are there any type of supplements for your research or foods that seem to aggravate arthritis, like whether it's red meat, sugar, vitamin E, vitamin D, fish oil?
Great question. I think that, and not to remain decidedly vague, but I think the lower inflammation the lower inflammation you have, the better. And so kind of the low inflammatory diets tend to do better. Things like the Mediterranean diet, I believe the DASH diet does pretty well. And I'm not sure on like this much olive oil or this much fish oil. I do think a calcium vitamin D supplement, especially in Spokane, because we never see the sun here, tends to be really a good idea for overall bone health. And that plus the regular activity and exercise tends to do well. Yeah, great question. So I don't have the specific, this is the thing you should definitely do, but I do like a calcium vitamin D and then kind of walk through a few different options for folks.
You make platelet rich plasma. You expand on that a little more and what the cost and
So platelet-rich plasma is a substance where you withdraw some of your own blood. We use a centrifuge to spin it down. We take components of that, namely platelet-rich components of it, and re-inject it into the knee. It's kind of the antithesis of the steroid. The steroid is an anti-inflammatory. The platelet-rich plasma is actually a pro-inflammatory, so it induces inflammation. In as much as it does that, it can potentially increase blood flow because your body recognizes there's something that needs to be addressed. I always cheesy phrases I use, but that's primary care medicine. Like blood is health, and the idea is that when you don't have good blood flow to a region, for us, certain areas that get fractured, post-surgically, if someone has poor blood supply or poor vascular status in their knees, they're not going to be a good surgical candidate because they're not going to heal well. So the platelet-rich plasma idea is that if we can induce blood flow, if we can induce the body to recognize there's something there and it floods it with blood, it can in turn reduce symptoms. The evidence is pretty decent for knee OA, knee osteoarthritis. It also can be used for lateral epicondylitis, so the old classic tennis elbow. But the overall, it has some mixed evidence. As far as cost, it is a cash injection, and so it depends on where you go and who you see, and the market's changing all the time. I have some partners who do it. I don't do it myself right now. We're working on some standardized policies on that. But a lot of folks will do it in town. But if I can give any advice when it comes to regenerative medicine, like PRP, stem cells, ozone injections, do your research and shop around a bit. Because I think it's pretty sad when an injection costs $1,000 at one clinic and $10,000 at another clinic. I think it's pretty unfortunate. So just, yeah, keep it standardized and do your homework on that before you write them a big check, because that's not very fair to you guys. Anything else?
Is cortisone considered a steroid drug?
Yes.
It is. And I have a couple of questions.
Yeah.
What are the besides what you said about possibly increased arthritis, what are the side effects are there?
So the two that I worry about in the acute phase is elevation of your blood glucose, although it tends to be fairly transient over the course of 2 days to 2 weeks. And so with my diabetics, if your A1C is over 8, I usually will not do a cortisone injection, or I'll taper it to a lower dose. It also can increase your blood pressure. If you have repetitive or repeat steroid injections in close succession, I believe it can have a bit of an immunosuppressive component, so it can reduce your body's ability to fight infection. And so you have to be conscientious of that, especially if you have someone who's immunocompromised at baseline.
Because I'm using it right now for plantar fasciitis, and I just had a shot with the cortisone about a month ago. And it was about, you said that it would be anywhere from not effective at all to up to 100%. For me, it was probably about.
I like those odds. It's going to be between 0 and 100. I promise you that. Yeah, that's one of the things I can get behind. Yeah.
So I'm probably at about 75%. So I'm going to go back on Monday and get another shot. You said that's what you recommended. Is that too soon though?
When was the first one?
About a month ago.
It depends on the individual. One of the things that you have to be careful with cortisone or steroids, because they reduce blood flow, they increase the risk of cartilage degradation. They also increase the risk of ligamentous and tendon rupture, or tissue breakdown of that soft tissue. There's also a risk of a fat pad atrophy, where it actually can shrink the fat pads. Those are normal fat pads in your feet and your joints to protect those joints. So I usually recommend not doing steroid injections in closer succession than every 12 weeks, except for kind of one-off scenarios where it's golf season, or you're going to Europe and you want to do another one at 10 weeks instead of 12 before you go. Okay, fine.
So I should probably wait.
Yeah, and I think too, for me, the steroids aren't a cure-all. They reduce the inflammation, but appropriate insoles, physical therapy, working on arch strengthening, that's what's really going to cure it in the end.
Well, I've done that too. I've had the insole specialist.
Did you ever tape it at all? Did you ever tape your plantar fasciitis?
No, I haven't tried that.
Come find me at booth 21 after this. I'll show you how to tape it. Took mine away in 3 days. I had it for a year and it went away in 3 days. I had an athletic trainer show me how to do it when I was doing my training at Virginia Tech. And I said, all right, I'll steal this because it's zero risk. It keeps you, no guarantees. It's a 0 to 100% chance of working. I should be very clear on that. But I'm happy to show you my taping technique.
Would a representative paper for rheumatica produce some of the bad symptoms that cortisone injection?
Yeah, the prednisone taper for autoimmune conditions, if you will. Would it predispose you to some of those things? Yes.
9-month paper, and I'm just wondering if that's stimulated on the other office.
It's really hard. The systemic long-term steroid tapers are really, I'm sorry guys, I'm standing under a speaker. I'll back up. The systemic medications carry a bit of a risk with them, certainly. What really makes the injections a higher risk in my world is that it's directed specific, it's in that small location and it's much more potent. So because it's systemic, yes, could it be a risk, but with systemic steroids, I'm a lot more concerned of other things like long-standing, immunosuppression and glucose elevation and cortisol interruption or irritation, things like that. So, yeah, so it's certainly something to keep an eye on, but no, it tends to be, I think, less directed to the joint. Anything else?
For exercise, weight-bearing exercise versus swimming, Pilates, yoga, I mean, somebody address.
Okay. You know what, guys? I'm just going to excuse my colleagues. So it's a great question. I think that I know weight-bearing exercise is shown to be not only a treatment, but or not only preventative, but potentially treatment for osteoporosis or thinning of the bone. So as much as you're able to, I do think weight-bearing exercise and in particular muscle weight exercises are important. My favorite recommendation, especially for folks as they get above about 45, is band exercise. Again, geeking on the biomechanics. If you look at an elastic band, it's not a linear weight. So if I pick up a 20-pound dumbbell, it weighs 20 pounds here and it weighs 20 pounds here. Whereas an elastic band, at your strongest, the further you are in that contraction of the muscle. And so an elastic band weighs 5 pounds of resistance, or gives me 5 pounds of resistance here, and then hits 40 pounds as I get to the top. So it's a much more dynamic lift. We see this in collegiate athletics. I'll geek on you for a minute. It's pretty cool. We put chains on the barbell while they're doing squats. So at the bottom of the squat, which is the weakest point, they have 300 pounds on their back, and at the top of the squat, they have 500 pounds on their back. So it's kind of a fun way to really, and it sounds cool and it looks cool, because that's what matters when you're 19. But the point is, I really like elastic band work. I like weight-bearing exercises. I really like swimming when we talk about non-weight exercises, because swimming is crazy dynamic in that it's resistant in every motion, right? So if I take a dumbbell and I lift it up like this, it's biceps, and then it kind of relaxes or it works the biceps on the way down, but my other muscles aren't doing anything. Whereas when you're doing a crawl stroke, every muscle you use, and then as you bring your arm around, every time it's working in all planes. So I think it's really good for function. Balance work and Pilates, I'm a huge fan of. I'm trying to encourage some of my young athletes even to get over this idea of kind of Pilates as for dancers or people who aren't contact. The special operations guys and our folks and the high-level collegiate athletes are recognizing the power of Pilates. So I'm a huge fan of Pilates. I push it on a lot of my athletes and say, do as much as you can. It's low impact, it's low risk. And for those of you who are golfers, I know that I had a mentor of mine who said in his late 50s he added 30 to 40 yards on his drive, which is pretty impossible at that age statistically. But he started doing Pilates and he had a lot better back rotation and a lot more mobility, and so he was better at golfing.
Now, I'll just piggyback. I agree with everything Dr. Strasser said. I think to kind of focus in on your question a little bit too, I agree the weight-bearing exercise is important for our bone health as well as our muscular strength. But there is a balance between doing high-impact weight-bearing exercises and lower impact. So, walking versus running or, things like that. And agree with, kind of the Pilates, the yoga. The more core strength you can do, the more flexibility you can have. Really helps, your overall, not only body, but joints especially, just keeping you mobile, keeping you kind of, flexible, but also strong that way. And it doesn't require, a lot of high-impact type of activities to do that.
One more quick comment. One of the things that I think we're afraid of most, and this usually falls in my partner's wheelhouse, is hip fractures. They just have a lot of, it's just a bad injury to get. And so if you can mitigate some of that risk by improving your balance through the core work, through the balance work, that's a worthy goal. Let's put it that way.
If any of us in here need any help, where would we find you guys?
Yeah, I appreciate that. I think we're at booth 21, and then we'll have some cards for you. And then we're located north, south, valley, downtown. We have medicine will travel, so we'll come to you if need be. But yeah, we'll find a way to follow up with you. We'd be interested in talking more. Thank you. Anyone else? Sir, take us home.
I avoided going to the gym. I belong to vitamin C because they are paid for, which is one of the problems. And it's a nice place to look out. I will not send them without your parallel because of the community. So we haven't gone. Because of the high feel.
Yeah. I think again, risk benefit, you have a 0 to 100% chance of getting COVID at the gym. No, joking aside, it is a serious consideration. I think if you're appropriately vaccinated, that's helpful, obviously. If you don't have a cardiopulmonary condition, so if you don't have COPD or asthma or congestive heart failure, wearing a mask during exercise has not been shown to cause exorbitant amounts of strain on the cardiovascular system, so you can wear a mask, which helps mitigate some of the risk of spread as well. And then just common things, hand hygiene, wiping down the machines before and after use, and avoidance of close contact as much as you can. To me, I love the outdoors, so I say, hey, gyms are great, I'm all about it, but grab a pack of bands on Amazon for $40 and head out to a tree and do your thing on a trail. You know, that's my go-to. Yeah. Yeah.
It doesn't work your upper body. So if you want to work.
It doesn't work your upper body.
I mean, if you go out to the hike.
Oh, I see what you mean. Yeah.
Your upper body.
Yeah.
So,
my friend, find the biggest log you can, throw it on your shoulder, and just walk until you can't stand up, and you'll. I'm just kidding. I'm sorry. No, it is a challenge. You know, I think you have to see walking as a dynamic exercise, and it is hard to find ways to work your upper body. What I recommend is rucking, where you put weight or a weighted back on. Obviously, if you don't have back arthritis and things like that, but if you can put a 10-pound or a 15-pound backpack on, and you can walk uphill in some facet throughout that walk, it's going to work more than just your lower legs. It's going to work your glutes and your core. It's going to work your abs. And in addition to that, not to sound again like a broken record, but you bring an elastic band. It's light, and you can do elastic band work in all planes while you walk. So you have to make it a bit of a dynamic exercise. Is it as easy as the gym? No, not at all. But you can get creative and look at some alternative options. Yeah, but it's tough. A lot of people, we've been seeing a fair amount of injuries because people did nothing for 2 years. They sat at home, and that was the right move at that time. But getting back into it is challenging at any age, but especially as you get past about 40 years old. It's hard.
I was just going to recommend something I've been doing for a few years, which is using walking sticks.
Yeah.
Tech poles.
Good call.
With your
Walking
upper
sticks.
body, it's excellent.
I like that.
Excellent.
Weighted walking and walking sticks.
Yeah.
Good call.
I got a question, wondered for years and years, maybe you can answer it, but I've heard many times that a person falling down, breaking a hip. And then I just not long ago heard that, no, that's not true. What they do is break their hip and they fall down. Which way is it?
No, it can happen either way. So it happens both ways. It's really difficult to determine, based off of history. So, but either way is 100% possible, or 0 to 100%.
Since you're still taking questions. So a few months ago, I sort of tweaked my knee. I've never had any problems or pain. I've been lucky. But I sort of tweaked it, I think, walking too fast through an airport. And I've been waiting for it to self-correct. Do I need to just come in and have you put a microscope inside? Because I don't know why it continues to be a little problematic.
Yeah, that's a good question. And honestly, the only way to really know is to get it evaluated and worked up. That doesn't necessarily mean you need to, be surgically treated, but it does, if it's bothered you for that long, it continues to hurt you and provide restrictions, I guess I should say, to your daily activities, then by all means, yeah, it's I think worth your peace of mind to at least get it checked out.
I always tell folks that if it goes past about 4 to 6 weeks, and you're still noticing it, you should come in and get it looked at. That's beyond just the typical bruise, bump, scrape.
So I'm afraid I tore something.
Yeah. And of course, sooner than that, if it's debilitating, you have concerns. It doesn't have to be 4 months, but
No, CBD helps me a lot.
there you go.
It doesn't really hurt most of the time.
Or you can be like the 3 of us and just ignore it for 20 years until one of your partners has to see you and take care of it, which is another fee or way to go.
Do you have to be referred or do you have to go to our doctor? Or do you need to go there?
Great question. Do you have to be referred to come see one of us? I'm in a bit of a different animal, so I don't often need quite as much of a referral process. Certainly to the orthopedic surgeons. I think it's insurance dependent, of course, and that stuff is so changing so fast, and it's way above my pay grade, unfortunately. I don't have a good, clean answer for you, I'm sorry. But we're here to answer questions. And so I think, not just here today, but I mean in general, that's what we're here for. And so if you have problems or questions, certainly if you're in the MultiCare system, which we're all about, your provider can send me a message and say, hey, what do you think of this? Can you review this x-ray? Any of us. And I do that back and forth a lot. So there's a really nice streamlined approach on our electronic medical record. And then be like, yeah, that's something I should see, or oh, try this, and call me in a month and let me know. All right, well listen, thank you all for hanging to the end. Give us a shout if there's any problems or questions. We appreciate it.